Up next, we have Janardhan talking about augmented aspiration.
Good morning, everyone. I'm here to talk about the proximal end. What can we do to be able to augment clot removal? We've heard a lot about the distal end and how navigable and dimensions of catheters. So I'm here to give an additional perspective on augmented or cyclical aspiration. These are my disclosures. There's been a trend, whether it is in heart attacks, strokes, or VTE, there's been a trend away from infusing lytics, thrombolytics, and moving into catheter-based therapies, and also assessing procedural metrics. Just earlier this month, in addition to what we've already known about the stroke field and in the coronary space, the Peerless study was presented, which shows that in the VTE space, percutaneous suction thrombectomy is better than lytics in terms of clinical deterioration and hospital efficiencies. So I wanted to use this talk to be able to give some insights on cyclical aspiration, on larger clot burdens, as well as clots that are in bifurcations, that are non-linear clots. And I want to start with a short video that shows you how cyclical aspiration works. And so in the middle, what you see is a lollipop clot, which is an invaginated clot, which is much harder to remove. And you see with cyclical aspiration, it is leveraging a fluid dynamics to be able to remove this clot, and we'll talk about it later. If I had to broadly summarize the field of augmented aspiration, it can be broadly classified into two categories. Number one is hydrodynamic therapy. In this, the devices use a forward pulse of saline, and then in the second phase, they have a negative continuous suction. And all of these have variations of it, and I'll show you about it. And then on the second side, you've got computer-aided thrombectomy. And there are two devices that do that with Penumbra and Insera. And here, we will talk a little later, these are more advanced techniques, and they don't use forward pulse of saline. Now, if you start with hydrodynamic therapy, just to give an insight into how these devices work, so this is the traditional angiojet device from Boston Scientific. You've got some side pores where there's a forward jet of saline, and then certain additional ports wherein in the catheter tip that the suction pulls the clot in. This is the Abbott JETI hydrodynamic thrombectomy device. Here, the jet of saline is perpendicular to the lumen of the vessel in the first cycle of the phase, and then in the second cycle, you've got continuous negative suction. With Expanse Medical's ICE catheter, you've got a similar forward jet of saline and a negative suction in the second phase. Here, the catheter tip closes to enable vacuum. If you look at rapid pulse system, they again have a forward jet of saline and a negative suction in the second cycle. So what is the challenges with hydrodynamic therapy? In the interest of time, I will keep the literature for all of these implications that happen, and anyone who needs that, I'm happy to share it offline. So what happens when you inject a forward jet of saline is the red blood cells start swelling up, and they can actually get damaged. And because of that, the hemoglobin on the inside gets poured out, and this results in a form of hemolytic anemia, requiring blood transfusions and ICU stay. In addition, you can have sequestration of these RBCs in the spleen, causing splenomegaly, and in 30% of the patients in trials that have been published, there's a need for dialysis. They have 30% have acute kidney injury, and in 5% require dialysis. So these are some of the consequences of a high-pressure forward jet of saline. If you look at surgical aspiration in terms of computer-aided thrombectomy, they do not use a forward flow of saline, and they adjust the negative suction pulse. And in the Penumbra system, they have a first phase where there is an off cycle, and in the second phase, there's continuous uniform negative suction, and it oscillates between this off and on cycles. In the Insera system with the CLEAR Aspiration System, there is continuous negative suction, but the amplitude and frequency are varied. So there's always negative suction at the catheter tip. You don't have an off phase. And there are two versions of it. One is a blood saver mode and a turbo mode that tackle the safety and efficacy components. Now, how is cyclical aspiration achieved? And this is an example with the Insera system. So you've got a tablet that can connect with via Bluetooth to a chip inside the vacuum system. And there is a motherboard on the inside that makes an impact on the speed as well as torque of the vacuum pump. And by doing this, it's able to generate these cyclical algorithms, one which is a blood saver algorithm whose objective function is focused more on safety, so there's more blood loss, and the second, which is a turbo algorithm that's objective focus is more on efficacy for adherent clots. Now, if you just look at the whole field of augmented aspiration and just try to understand what are the nuances over here, if you look at the rapid pulse system, the pulsatile vacuum is generated in the generator or the pump. With the Penumbra system, it's an adapter on the canister. With the Truvik system, it's in the on-off switch of the tubing. And with Expanse Ice, it's at the tip of the catheter. With the Insera system, there's a motherboard on the inside of the digital pump, and it generates these algorithms. Now, how does cyclical aspiration actually work better than continuous uniform aspiration? And I just want to take a minute on this slide. So you see there's different types of clot types in different locations of the body, varying from RBC to fibrin and a mixed composition. And so what we started off with is a simple waveform that is the first harmonic for an RBC clot. And we realized that as there is more fibrin composition, you need to change this harmonic. And so you get the second harmonic, third harmonic, and fourth harmonic. And this then translates into a square wave approximation that generates these cyclical algorithms. And the proprietary fluid dynamics over here that is at the core of this, you can look at it as a triad, and it depends on which type of clot you're dealing with. One of the three vertices of this triad come into play. The first one is there is static friction when the clot is adherent to the wall. And to be able to pull this clot out, your suction force has to overcome the static friction of the stickiness of the clot to the endothelium. And what we achieve with cyclical aspiration is by stretching and relaxing the clot, you're converting that static friction to kinetic friction, which is easier to overcome.
Time.
Yeah. And then I'll just wrap up with the last two aspects. And the second aspect is the viscoelastic properties of the clot. You've heard of Hooke's law. And so if you maintain the cyclical aspiration within the elastic limits of the clot, then you're not going to fragment the clot, and that's another benefit. And the third one is eddy currents that through microfluid channels, they milk the clot into the catheter like a snake eating a meal. So that's the summary of augmented aspiration. I hope this was helpful. Thank you for the time.
Thank you very much. Obviously, we have many, many options. Great talks. Next.